Hello, and welcome to today's webinar, focusing on nutrition and diabetes, special considerations for adults experiencing homelessness. My name is Darlene Jenkins, and I will be serving as your moderator. This webinar is being conducted in recognition of National Diabetes Awareness Month and is presented by the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation, and we will cover these overall learning objectives. We have reserved the last 10 minutes for Q&A. There is a chat box below the presentation of the slides, and so this is where you would be able to type your questions throughout the presentation or anytime during the presentation, as well as if you are experiencing technical issues, please type them in this chat box as well. You may also call the Council office at 615-226-2292 and ask for Julia for assistance. At this time, I'd like to introduce our speakers for this hour. Joining me is Dr. Veronica Oates and Ms. Tracy Tinker. Dr. Oates received her doctorate in nutrition from the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill. She is a licensed, registered dietitian nutritionist and currently an associate professor at Tennessee State University. Dr. Oates' research interests include childhood obesity prevention, weight maintenance issues, and the influences of culture and media on health. Ms. Tinker has been a nurse case manager at the Healthcare for the Homeless program of Catholic Medical Center in Manchester, New Hampshire for 8 years. As a certified diabetes educator, she is a passionate advocate for client-centered goal setting to help her patients successfully achieve their self-management goals. In 2013, Tracy partnered with us and a multidisciplinary team to update our diabetes adapted clinical guidelines that help us address the special challenges of clients who are experiencing homelessness. These guidelines may be found on our website, and we give the address for our website at the end of this presentation. As we begin to talk about diabetes, we want to focus on a little bit on the broad issue of it as it affects adults in the United States. This map just gives you an idea of what the percent of adults diagnosed with diabetes in the United States in 2015. For the darker areas of blue, this is where the percent of adults with diabetes average between 9.7 to 15.2%. And so you can see that there are several states that are very dark and blue. If you go on the CDC site, you will see, and the sources given there, you can track across the years how the states have become darkened over the years by the increased percentage of adults with diabetes. As we look at the number of, again, adults with diabetes diagnosed, the yellow line here is the percent of individuals with diabetes. And this graph shows from the years 1958 to 2015. In 1958, the percent of adults diagnosed with diabetes was 0.93%. And then it increased to 7.4% in 2015. The blue line on this graph shows the number of individuals with diabetes. So the yellow line is the percentage, and the blue line is the number of individuals. And as you can see, again, there is a big increase from 1958 where 1.6 million people were diagnosed with diabetes, to 2015, and the actual number of individuals diagnosed with diabetes was 23.4 million. As we look at 2017, the latest data that has been shared from the CDC, we now have 30.3 million people diagnosed with diabetes. As we compare between, again, the 2015 number was 23.4, and now just within 2 years is 30.3 million. So that's about an increase of almost 7 million more people diagnosed within this 2-year period. Again, we have a number here that 7.2 million are undiagnosed, or 23.8 people are undiagnosed. And then it shows also from the information that we have gathered from the data given or presented by CDC that those with less than high school education, the percent of individuals diagnosed with diabetes is 12.6% versus those with a higher above high school education is 7.2. We did an analysis here at the council just trying to look, kind of zeroing in. So we looked broad, we just gave the information regarding the national numbers. Now, we wanted to focus on just health centers, especially health centers that receive 330H funding, or those who are serving individuals experiencing homelessness. And we see, again, that there is an increase over the years. From 2012, there's 68,851 to 2016, and we're using the information that was captured in the Uniform Data System, the UDS. So there was approximately 18,000 more patients diagnosed with diabetes between the 2012 and 2016. In the recent special issue of the Primary Healthcare Digest that was just sent out this past Monday, it was written that at least 1 out of every 7 patients who walk through a health center's door has a diagnosis of diabetes. So we know that the prevalence of this disease is very high in individuals, not only receiving care at health centers, but also health centers that are receiving the 330H funding. As you look at the percentage of diabetes, again, who are being served at 330H health centers, we see that the percent over the years was somewhat stable between 2012, 2013, and even 2014, and then it took a dip in 2015. We're not quite sure about the dip there, but we're thinking that we were doing a good job diagnosing as well as treating. But now the prevalence and the percent of uncontrolled diabetes for patients in 330H health centers has increased to 35%. And again, this is data that we have received that we analyzed from the UDS, the Uniform Data System. Why we have that spike, we don't know, but extra effort is being and extra focus is being now focused on diabetes. And you'll be hearing more about different opportunities, learning opportunities from the council focused on diabetes and helping health centers to address some of the issues. We recognize that there are many factors that affect diabetes control. One is unstable housing. We know housing is a major social determinant of health, and if a person is worried about where they're going to sleep or where their next meal is coming from, that does have an effect. That stress, overall stress, has an effect on being able to control one's blood glucose, as well as oral health. We know that individuals who are experiencing homelessness many times eat a high processed sugary carbohydrate diet and also don't have many times access to toothbrushes or toothpaste, and so dental caries are high in individuals with experiencing diabetes, and oral health with infection in the mouth can affect, again, diabetes control. Medication storage, having a safe place to store one's medication or having their medication or syringe and needle stolen is also an issue. And then finally, nutrition. And today, that is the one factor that we will be focusing on and hopefully putting a spotlight on, giving some solutions and suggestions regarding how we can address nutrition in populations experiencing homelessness, also diagnosed with diabetes. So I'm going to turn the webinar now over to Dr. Oates, who's going to focus on the nutrition part of our presentation. Dr. Oates?
Good afternoon. So today I want to talk about why maintaining blood glucose is so important for health and how nutrition can play a role in helping those with diabetes. Diabetes is considered a metabolic disorder which causes elevated blood glucose levels, and so nutrition is important for good health, but it can be a challenge for homeless people. And managing diabetes, whether you're homeless or not, is a challenge. So being homeless, it actually makes it more challenging. So I want to discuss some tools that can actually help you with your clients who actually have diabetes. So normally after a meal or a food is eaten, insulin signals the cells to receive glucose from blood. But with people with diabetes, they either have insufficient insulin production, ineffective insulin production, or a combination of both. And this is important because every body cell actually depends on glucose for fuel to some extent, and then our brain and our nervous system almost exclusively rely on glucose. So glucose has to remain within limits that allow the cells to actually receive nutrients and not just the energy from the glucose. So blood glucose ranges, the normal is having an A1C level of less than 5.7%. And when we start looking at A1C levels, that test is basically just measuring the percentage of a person's hemoglobin that actually has glucose attached to it. And so the higher the percentage, the higher a person's blood glucose level has been over a period of time. Red blood cells live about 3 months, and so the A1C test actually provides a long-term or an evaluation of glucose control over the past 3 months. So for normal, there are different ways that can be tested. Of course, a blood test with the A1C level, but also if it's fasting, then they can look at what the level should be. And for normal, it would be between 70 to 99 milligrams per deciliter of blood. And if they have eaten after a meal, so sometimes people can get an oral glucose solution to be tested, and then they look at it an hour and then 2 hours after the meal. And the level that you want to see is less than 140 milligrams per deciliter 2 hours after a meal. So for somebody who's been diagnosed or maybe told that they have prediabetes, these are the levels. You're looking at an A1C level of about 5.7 to 6.4%. The fasting level would be between 100 and 125 milligrams per deciliter. And then at 2 hours after a meal would be 140 to 199. So for persons who have been diagnosed as having diabetes, their A1C level is consistently 6.5 or higher. When they're fasting, it's over 125 milligrams per deciliter. And then if they're 2 hours after a meal without medication, it's still above 200 milligrams per deciliter. So when we start, again, thinking about blood glucose, well, where do we get it from? Glucose comes from carbohydrates, and you'll hear a lot of different things. Oh, you shouldn't eat carbs, or stay away from white carbs, but we're going to try to get to the nitty-gritty of it. The idea is that all fruits, vegetables, and grains contain carbohydrate. Now, the components of carbohydrate are sugar, starches, and fiber. And then we have what people talk about complex carbs. Those tend to be our vegetables, our grains. And then fruits vary in the amount of carbohydrate because some fruit is riper than other fruits. So what we're concerned about when we think about how people can maintain this homeostasis, again, managing within normal ranges the blood glucose levels, it's not just the carbohydrates, because if a person is not, or if the body doesn't think that they're getting enough energy, or like when we're fasting, your body will actually make glucose from protein as well as fat. So those are some things to think about. How we regulate normally with our blood glucose levels, we do it through insulin, which most people know about insulin, also glucagon and epinephrine, and then there's some other hormones, what Dr. Jenkins was talking about when she mentioned stress that can be released. So epinephrine is one of those stress hormones. But glucagon is the one when we're fasting, so we haven't eaten. Glucagon releases the glucose from storage that we have in our muscle cells and mostly in our liver as well. Other ways we can regulate our blood glucose level, of course, through food. Those complex carbohydrates, foods that have a lot of fiber, those help with not having such a high peak or spike in the blood glucose level. And of course, then physical activity, which is one of the things that when we think about good health, and part of a lifestyle is making sure people get enough physical activity. So being physically active, it actually causes your muscles to bring glucose into the muscle cells. So that's one way that people who have diabetes can actually help also control their blood glucose level. So the importance of nutrition for clients with diabetes who happen to be homeless, just like with everyone else, these complications can be acute and as well as chronic. So things such as blurry vision, poor circulation, having an increased risk for infections, those occur. But then the long-term or the chronic things would be the development of cardiovascular disease, having kidney failure, blindness, gangrene with the amputations. So the goal is always to try to maintain a near normal blood glucose level. And again, diet, physical activity, and medication. So diet is one of those, again, what we're going to talk about, but the importance of diet and treatment, unfortunately, I am a registered dietitian, so this does sound kind of self-serving, but it really can be managed with the help of a registered dietitian nutritionist. So the recommendations for people who have diabetes, basically I tell everyone, whether you have diabetes or not, this is what you really want to do. Make your carbohydrate intake consistent and spaced out throughout the day. So the idea of having like 3 meals a day or 2 snacks, the real idea is, I know some people don't want to eat a meal. A meal doesn't have to be very large. The idea, though, is that you're not going any more than, let's say, 4 to 6 hours without having eaten, except for when you go to bed and you sleep overnight. But your body has a way of regulating that with, again, that glucagon being released, from glycogen being released from your liver overnight when you sleep. But that's another idea. But just to maintain your blood glucose level is a very good idea. Not getting too hungry, because when people get too hungry, they tend to overeat, and then that can cause those spikes as well. Making sure what they're eating, so it's not so much staying away from carbohydrates, is what carbohydrates you're eating. So making sure that you're doing complex carbohydrates. And I have a list we're going to go through of what the better foods are to eat. So another way to help with people who have diabetes is eating a variety of of these different types of meal plans. So the DASH diet, which is just the dietary approaches for stopping hypertension, another popular diet. Mediterranean diet, a lot of people have heard about it, and having a plant-based diet. So this is another thing. People who have diabetes can still be a vegetarian. So recommendations, always consider the source of the carbohydrate. And again, although we're focusing on people who have diabetes, these are things that everyone should be eating and how everyone should be eating. So our carbohydrates should come from vegetables, fruits, whole grains, legumes, beans as well, low-fat, non-fat dairy products. Always, another thing that people can do is consider, I wouldn't say always, but consider the glycemic index. And so when I talk about the glycemic index, this is just the rate in which foods happen to raise the blood glucose level. So some things like rice, they may have a higher glycemic index than things like brown rice. The issue is you also have to think about when you're eating food what you're eating with it, because if you're eating a combination of foods, that can also decrease the amount of the absorption of the glucose, and so then it won't be such a great spike in your blood glucose level as well. How food is prepared also can affect the glycemic index of foods. Another thing that you want to do, and then again for all people, reduce the saturated and trans fat intake. So that's when we start looking at those long-term health effects or chronic effects that can occur from having diabetes, the development of cardiovascular disease. So very little trans fat should be in the diet, and if you're looking at, with your saturated fat, no more than 10% of the fat calories should be saturated. Also, avoiding foods that have added fats, sugar, and sodium. And I think that's self-explanatory. So one method that is a popular method for persons who have diabetes, especially if you're serving people, homeless people, is using the plate method. It's a visual tool, and the idea is that half of the plate should be vegetables. Then one section or a quarter of the plate should be starch and bread. Half of the other side, should be starch and bread, and then the other section would be for your protein source. So the idea is that your starches and bread, they do raise the blood glucose. So your vegetables have little effect on blood glucose, and then the meat or your protein source also may slightly raise, but typically it just really depends on what it is that you're using as your source. So 5 steps for using the plate method. Basically, the first thing you do is you just visually divide the plate in half, and then again, one side will be filled with vegetables and what we consider non-starchy vegetables. Okay. The other half would be divided, and then again, 1/4 of that would be the protein in one section, and then the grain and starchy food in the other section. On top of that, you would add a serving of fruit, a serving of low or non-fat dairy, and then a low-calorie drink. So some examples of non-starchy vegetables. This is the list: eggplant, cabbage, broccoli, beets, Brussels sprouts, kale, artichoke. The ones that actually have the asterisk on it, the broccoli, the kale, and Brussels sprouts, these are ones that are also high in protein. So it's just something else to think about. They're non-starchy, and so if you can get these foods and serve those are really good choices for persons who have diabetes, as well as those who don't. It's very healthy food. Our starchy foods or starchy vegetables would be this list. So things like green peas, rice, even brown rice is still considered a starchy food. It's healthier because of other nutrients, but it is still considered a starchy food. Lentils, butternut squash, quinoa, healthier choices because they are still higher in protein, but they're still considered starchy. Then our meat and other protein, so your beans and lentils, nuts and seeds, fish, seafood, chicken, turkey, beef, and of course when we're looking at animal sources, we want to make sure that they're lean cuts of meat because that's going to, again, lower the amount of saturated fat that's actually served. And that's it. I have some resources of some websites that people can go to and a book that's really helpful. And so now I'm going to turn it over to Tracy.
Thank you, Dr. Oates. So what I would like to do today is talk to you a little bit about assessing clients and then partnering with them to help them put into place some of the things that Dr. Oates was just talking about. So I'm first going to talk about assessing, helping to identify financial barriers, and especially those barriers that are related to nutrition. And then I want to share a couple case studies with you on how we actually put this into practice. So I'd like to start for context with the social determinants of health for people who are homeless.
This comes from the Healthy People 2020 Social Determinants of Health. And why this is so important in what we're talking about with diabetes and especially with nutrition is most of our clients spend maybe about an hour with us. That might be an hour with us a week, an hour with us a month. But the rest of that time, they're in the community. So their ability to obtain healthy foods and to eat healthy is really related to their neighborhood, their health and their access to health care, their social and community context. As you saw earlier, the rate and percentage of people with diabetes can be related to their level of education. Also, their level of education, their literacy, and their health literacy all affect their ability to take care of their diabetes as well. And then, of course, their economic stability. Do they have access to food? Are they food secure? And do they have access to housing? And as we go through here, I'm going to mention many of these things and talk about how you can assess people and then what the resources to address those might be. So we're going to start with talking about food insecurity. This is the NHANES study, the National Health and Nutrition Examination Survey from 2005 to 2010. This was a very large study that looked at 16,934 U.S. adults from 20 and older, and it found that 19% of U.S. adults were identified as food insecure. And the way that they were identified as food insecure was using the USDA U.S. Household Food Security Survey module. This comes in 18 questions, 10 questions, and 6 questions. The 6-question version I'm going to show you was actually validated to be as valid as the 10 and the 18 question. And just so that we're all kind of on the same page, the definition by the U.S. Department of Agriculture for food insecurity is having inconsistent access to adequate food because of limited financial and other resources. These are the 6 questions that are on the USDA Food Insecurity Survey. And the first one we find very often here in our clinic, and this is people that even if they have access to supplemental nutrition assistance benefits or SNAP, they often experience difficulty obtaining food at the end of the month. So it could be important when you're actually administering this survey because the answers could be different based on what part of the month that you're asking the question. So the first one is that they bought food but it didn't last, and they didn't have any money to get more. Second, they couldn't afford to eat a balanced meal. And then the third question is, since the last month, did they ever cut the size of the meal or skip a meal because there wasn't enough money for food? Depending on their answers to AD1, they're then directed to a second page. Oh, I'm really sorry. It looks like this is, but let me read those questions. AD1A says, how often did this happen, referring to the last question about whether they cut the size or skipped meals. And they respond almost every month, some months, but not every month, or only 1 or 2 months. And then everyone answers, in the last 12 months, did you ever eat less than you felt you should because there wasn't enough money for food? Yes, no, or I don't know. And in the last 12 months, were you ever hungry, but you didn't eat because there wasn't enough money for food? And again, yes, no, or I don't know. Depending on their responses to these 6 questions, this survey tool can be scored. And even if they have more than 2 or above, you should suspect that they have some food insecurity. So 2 to 4, low food security, and 5 to 6, very low food security. Well, why is this important? Well, this is important for a couple of reasons, and these data come from the NHANES study. In those who were food secure, they were asked, in the last month, how many days would you report that you felt your physical or your mental health was not as good? If you were food secure, you reported that your physical health was an average of 3.2 days was not good, and your mental health was 3.4 days was not good. If you were food insecure, almost twice the number of days where you felt like you had poor mental health or poor physical health. So a direct correlation between your ability to access the healthy foods that you need and your self-reporting of whether your mental health or your physical health was good. Food insecurity is also related to diabetes. If you were food secure, 8% of the patients in the NHANES study had diabetes. If you were food insecure, 9.3% of those patients had diabetes. So not only is there a correlation between your level of education and diabetes, there's also a correlation between your ability to access healthy foods and have diabetes. This was also looked at in a study published in 2011 in the Housing Instability and Diabetes Self-Efficacy in the Journal of Healthcare for the Poor and Underserved. And what the authors found was that inadequate access to food lowers your self-efficacy among adults with diabetes. What the authors wanted to tease out in this study was this related to someone's ability to have housing or their income or their ability to obtain food? What they found was that there was a direct correlation between housing instability and food insecurity. They looked at a subset of patients who reported that they did not have a place to live. 100% of those patients that were reporting they had no place to live were food insecure. And the authors concluded that it was the lack of access to food rather than low income that most affected somebody's ability to manage their diabetes. So where can someone who is maybe food insecure or maybe homeless, where are they able to access resources? There's a website and a phone number at 211.org, and anyone can go on to this website and you can put in where you're located, and it will tell you where there might be free meals that are being served, where the food pantries are. Here in New Hampshire actually has created their own website at 211newhampshire.org, so you can go on there and find access to food pantries, access to food shelters, access to where there might be free meals being served during that day. Also, SNAP benefits can be used at farmers markets. If you go to the USDA.gov website and search for farmers markets, you can find in any state across the U.S. where the farmers markets will accept the SNAP benefits. Here in New Hampshire, not only can you use your SNAP benefits, your EBT card, at the farmers market, but they will actually give you a voucher to double the amount of produce that you can purchase at the farmers market. So it's a great way to get access to healthy foods for clients, as well as even doubling the amount of healthy food that they might have access to. Building on what Dr. Oates was teaching around the plate method, I had the opportunity, our clinic is located in the basement of the largest shelter here in New Hampshire, and upstairs is also a soup kitchen. So these are some examples of some of the meals that were served in the soup kitchen. So one of the things that we teach is very often we use the plate method, especially if someone is accessing food at a soup kitchen or maybe a church that's serving meals where they don't have the ability to load their own plate or they don't have the ability to cook the food themselves. So as you see in these meals, every day that a meal is served here, there is always a salad available. So we teach them that that is their vegetable. Unfortunately, there is quite a bit of carb on this plate, and a lot of it's simple carb. But some of the things that we teach are things like, in the upper left-hand corner, you see a very large roll. So what we will do with that roll is actually have the person take half the roll away, cut the other roll in half, and put the meat back and make a sandwich with all of the meat but only half of the roll. That way they're getting less of the carb that they would normally get. We also work with them to set goals, like if they are eating at a someplace lunch, like maybe a church that's offering a lunch, and they're offered a dessert at lunch, and then they're eating again at supper at the soup kitchen that's offering dessert again, would they be willing to just eat the dessert once during the day instead of eating the dessert both times? So looking at applying a harm reduction approach to their desserts and having them set achievable goals that they can work on. Then over time, working with them, they might then drop down to maybe 3 desserts a week instead of a dessert every night. We also talk about the breakfast, which can be difficult because often it's cereal and bread only for breakfast and very little access to protein. Choosing to do the bread and put some peanut butter on it over the bowl of cereal and putting a glass of milk on the side to get some extra protein so that they can then get some access to protein at a meal that they might normally not have a lot of protein access. I'd like to talk a little bit about literacy and health literacy. This is the Agency for Healthcare Research and Quality, and they have put out a Health Literacy Universal Precautions Toolkit. This toolkit can be used to help practices assess their health literacy messages for their clients. This helps because with people with diabetes, as you can imagine, there is a lot of numeracy that goes along with diabetes. So being able to assess a client and your practice's ability to talk about those numbers, but also the client's ability to use those numbers can be an important thing for you to know as you're teaching your clients how to manage their carbohydrates and build a healthy plate. It also, the numeracy and the literacy can make it very difficult to manage a chronic illness. If you're asking someone to complete a logbook, but they're not able to read, write, or understand numbers, it can be very difficult for them to work with a logbook. And I want to talk a little bit about how we've addressed that specifically in one of the case studies. This resource is from the Association for Clinicians for the Underserved. They've partnered with the Nurse Practitioner Healthcare Foundation to produce this tool that's shown here on the right. This tool is offered on their website, and the website's listed here on the slide, in both low literacy as well as very low literacy. On the left is another tool that was done by the Association for Clinicians for the Underserved with a company called Diagnostics, and they actually developed a tool that is written at a low literacy level. And all of these tools are free at their website. I'd like to move on now and talk about some case studies. My first case is we'll call him Kenny. He's a 60-year-old male. He has type 2 diabetes. Recently, Kenny came to see us, and his A1C was rising, so he was started on insulin. We do the insulin starts here. We have the patient come in and do their first injection with the certified diabetes educator with me. So we actually sit down and we go over and do a teach-back method where we demonstrate how to use most of the time it's insulin pens, demonstrate how to use the insulin pen, and then the client can then return demonstrate the use of that pen. This patient is morbidly obese. He does have insurance. He's got Medicare with QMB or Quimby, which helps him pay for the premiums and for his A and D for his medications. And he lives in what we call an SRO, or a single room occupancy. When he first came to see me, Kenny wasn't eating any vegetables. He had not ever grown up eating any vegetables, wasn't buying any vegetables. I had a group class, and Kenny was in the class and actually was encouraging other attendees of the class to eat vegetables. He now goes to our local grocery store. He learned that he likes vegetables that are frozen. He will buy frozen vegetables, and he tries to now have a vegetable at least once a day. The other thing with Kenny is he has a very low literacy rate, but I taught Kenny how to check his blood sugar and how to record it in the logbook. And when he started on the insulin, we taught him how to titrate or slowly increase his insulin to target. So he is increasing 1 unit on his basal insulin every 3 days with a target to start at 150. So he's been working on that. When he comes in to see us, he always brings his meter and logbook, and he's got a completed logbook, and he's writing down every 3 days what his new insulin dose is. Kenny actually shared with us that he has only a 4th grade education and has a very low literacy rate, but even given that, he is able to keep a logbook, he's able to titrate his own insulin, and he's really on the vegetable bandwagon to the point where he's trying to sell the vegetables to other clients who are not liking vegetables. My second case study is Mary. She is a 30-year-old female. She's had type 1 diabetes for 15 years. She is living here at our shelter, and sometimes she's living outside. She does eat at the soup kitchen. She has been hospitalized multiple times at our local hospital in diabetic ketoacidosis. Diabetic ketoacidosis occurs when someone has type 1 diabetes but does not have any insulin on board. Without any insulin, the body is not able to get the sugar from the blood into the cells where it's used for energy. If there is no energy, the body will start to break down muscle, and a byproduct of that breakdown is ketones, which are very acidic to the body. Unfortunately, in someone who is hospitalized multiple times, that can lead to death ultimately. Mary was struggling, so every month she was going into the hospital in diabetic ketoacidosis. She was relating to us that she didn't feel like, because she was at the shelter or staying outside, she didn't feel like there was a safe place for her to take her insulin. So she was skipping multiple insulin doses. Unfortunately, ultimately, Mary was hospitalized for diabetic ketoacidosis. She did develop sepsis and unfortunately has passed. So having this, not having access to a place where she felt like she could safely take her insulin and safely eat a meal ultimately resulted in multiple DKA admissions, and there's data that shows with multiple DKA admissions, the risk of adverse outcomes, including death, is highly increased. I'd like to finish with this quote from Dr. Martin Luther King, Jr., and this was a quote from a speech he gave to the Medical Committee for Human Rights back in 1966. He said, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." I'd like to turn it back over to Darlene now.
Great. Thank you so much, Tracy. We're now opening our question and answer time, and if you have any questions, please type them into the chat box, and we will answer them as they are presented. Does anyone have any questions? If not, I do want to ask, Tracy, thank you for sharing some of your, the case studies. I wanted to ask about Mary's case. What do you feel could have been done differently, perhaps, or for patients who also may have the same type of issues with DKA? What other measures or prevention measures can be used for clients with type 1 diabetes and may have the same issues as far as safety and access to food?
Thank you, Darlene. I think some of the things that might have been helpful, one is we do have a very active outreach team, and I think working with the social workers in the hospital so that they could notify us when Mary had been hospitalized, so we have that good transition. One of the really kind of could be dangerous kind of times are between that transition of care when she's going into the hospital and then getting discharged from the hospital. So we may have been able to have even more of a connection between those two so that we knew she was, each time she was in the hospital, we're sending somebody from our clinic right over there to meet with her at that time and work with her to make sure that she has everything she needs as she's discharged. I think another area that might be helpful is if there are, and unfortunately we don't have this now, but if we had areas in our clinic where she could come down and do her injections right in our clinic. We have a pretty small and we're limited on space, but if we had had that space, I think that would have been very helpful.
Great, thank you. We have a few questions that have come in. One is there a list of resources on our website? We currently do not have a list of the resources, but we will have them available in our slides, as well as the webinar where we post it to our website in 3 days. So you will have a listing of the resources that have been identified in this presentation posted to our website. Here's another question possibly for you, Tracy. What do you suggest as a method for keeping insulin safe?
That's a great question.
When living outdoors and with the temperature changes. Yeah.
That's a great question, and it's something we deal with a lot here in New Hampshire. It's hot in the summer and it's super cold in the wintertime. So one of the things we recommend is that when someone's going to, if at all possible, we try, if the insurance will cover it, to have them dispense pens and pen needles. So the pens, can be kept at room temperature, the one that you're using. When we ask the person to go to the pharmacy to get their medications, we ask them also to ask the pharmacy, can they just be dispensed one pen and keep the rest of their insulin at the pharmacy? If neither of those will work, we have sometimes kept people's insulin here in our refrigerator, but our first choice would be for them to try to see if they can just get dispensed what they're going to use and then keep the rest at the pharmacy. we're not a 24-hour clinic. The pharmacies are open longer hours, so they would have more access as well if it's kept at the pharmacy versus keeping it here in the clinic.
Great. Thank you so much. And here's another one for you, Tracy. Probably, is there any information available for staff who manages shelter kitchens? There's always a tension between preparing healthy meals and working with budgetary constraints. Our shelter relies greatly on donated food.
Yeah, that's a great question because we run into the same thing. A few years ago, though, one of the really pretty neat things we have here at our shelter is they were actually able to get a grant to build a greenhouse. So the growing season here is not super long, but at least in the summertime, we do have access to the vegetables that are grown in the greenhouse, and those are served at the meals. They also, when they hand out, we also have a food pantry, and when they hand the boxes out, they have a table where they're putting the vegetables on the table, and the people who are picking up their boxes can actually go over and grab the fresh vegetables. Unfortunately, many of our clients don't take advantage of the fact that there's a lot of vegetables sitting on the table. So some of that, I think, is an education issue, and we really need to spend a little more time educating people on the value and what they can do with those. If they have limited cooking space and utensils and abilities, can you could teach them what they can do with some of the vegetables that they might not be familiar with or that they may have not have tried before.
Right. That's great. Great.
So,
I'm sorry. Go ahead.
Okay. So this is Veronica. One of the things that I was thinking about, and I'm not sure, but it sounds like the question might be they prepare the food for them as well. So, of course, making or requesting donations from different grocery stores, et cetera. But here in Tennessee, we have a lot of agriculture, but there's some places that allow people to go glean. So after the crop has been harvested, you can get volunteers to actually go out to the different farms, and whatever they collect, they actually can keep. And I know some of our shelters do that as well. Some of the places who actually feed some of the homeless.
Right.
I just wanted to throw that in.
Yes, great. Thank you so much. Appreciate that. We'll take a couple of more here. I think this is for Tracy as well. Have you ever used a VGO insulin delivery device with your homeless population?
We have not used a VGO. I would love it if we could, but the majority of our patients, over 60%, have Medicaid, and we have Medicaid managed care in the state. The only clients that Medicaid normally will cover any kind of insulin delivery device or a pump with are patients who are experiencing gestational diabetes or pregnant type 1s or pregnant type 2s. So I don't have any patients in my population that are using either Vigos or insulin pumps. What we have used recently are some of the GLP-1s, the long-acting, so the Budgetary or the Trulicity. That has been very helpful for our clients because it's a once-a-week injection, and for those who are overweight or obese, it also can help people lose some weight.
Great. Thank you so much. I believe that there's a few others, but I think it says, do you think the soup kitchens and or food pantries will change the type of portions of food offered to those who participate? I think this is a great area where we can work to advocate for some of the changes that are needed. And the council is working with shelters. We have some interest in doing some educational opportunities with shelters regarding just some of the special needs. So I've seen this as an opportunity where we can provide some training, technical assistance, as well as resources to shelter staff and perhaps help with those conversations with shelter staff and health center staff regarding just the nutritional needs for clients. So I'll just say look forward to having the council have some resources that would help in this area regarding advocating with Shelters for Better Foods, also collaborating between health centers and soup kitchens as well as food pantries for better food. So look forward to hearing more about that. I think that concludes our question and answer. And again, I want to just reiterate that this session was recorded and we'll have a link to our archived webinar as well as the PowerPoint slides. And they will be emailed to all the registrants once it's been posted. Usually it's posted within 3 business days. And some of the questions that perhaps we didn't get answered during this round, we will try to respond to them and have them also posted on our website. Again, I want to show some of the different resources that are available. Some of them are specific to populations experiencing homelessness, and we'll have this on our website so you don't have to try to copy all this information down during this short period of time. This is the contact information. I want to also remind you that you will have a link to a survey to evaluate this presentation. It will come up as soon as we close out on your web browser, and we would appreciate if you would complete the survey so that we may be able to improve your future webinar experiences. And also there is a comment there or a question there. If indeed you are interested in joining a learning collaborative on looking at innovative ways to treat as well as to identify diabetes and to actually look at some of the outcomes regarding diabetes, there is an opportunity to join a learning collaborative that the council is doing in collaboration or in partnership with CSH. And so please go to the survey, answer question 5, email me, and we'll be happy to engage you in our learning collaborative that will be on diabetes. Are there any more suggestions or points before we sign off, Veronica or Tracy, for our audience, just to have any final points you would like to give or information that perhaps we have missed? I'll give you this opportunity. We have a few more minutes just to give you an opportunity if you have any other points or information you wanted to say.
Let food be thy medicine and medicine thy food.
Okay, great. Thank you so much. Great. Tracy?
I would just encourage people, if you haven't already taken a look at them, take a look at the adapted guidelines on the National Healthcare for the Homeless Council. Lots of great ideas for how to adapt national guidelines and apply them specifically to a homeless population.
Great. Yes, thank you so much. And we will be having a webinar focusing on the clinical guidelines sometime in March of 2018. So look forward for that information as well. And I believe with that we will conclude our webinar. Thank you everyone for participating. We greatly appreciate it.